up. We didn't have that much time, and we've got different subjects, and we haven't actually met. I've met Ed before, but this is the first time that we've met, and but I know that there's got to be questions from the audience, and so I really do want to be able to spend. Let's just, if people who have questions, does anyone have any questions? Michael Darcy, could you come up to the microphone, please? Just because this is being recorded and we want to make sure that we get, I don't know, it doesn't matter if maybe it doesn't, but go ahead.
My name is Michael Darcy. I'm the CEO of Gateway Foundation. We operate drug and alcohol treatment programs throughout Illinois as well as throughout the country. As I speak here today, we have 8,000 people in treatment in Gateway Foundation programs across the country. We're one of the largest providers. I want to salute to all of you for the fabulous, fabulous job that you did today. I learned so much. And I want to ask a question about the Obamacare, assuming it is sustained in the Supreme Court. My understanding, looking at it strictly from a chemical dependence treatment point of view, is that there are going to be many, many people that are going to be swept up who are in poverty now that don't have health care, that will have health care. And as a result of that, treatment is going to become accessible to all of these folks throughout the land. So from a treatment provider point of view, we're very optimistic about more people receiving treatment. And part of the Obamacare legislation that was passed was something which requires, it's called an accountable care organization. Essentially, the concept is that you get a big mega institution, let's say here in Chicago, like Rush or the University of Chicago, that's going to assume the entire care for an individual and collaborate with other social service providers to make sure that not only is the medical care delivered, but if they need drug or alcohol treatment, that's taken care of. If they need housing, that's taken care of. If they need mental health services, that's taken care of. So it's a sort of like a one-stop shopping, not that the hospital or the accountable care organization is going to control what's going on, but will partner with everything. Do you have an opinion about that and what that will mean for services going forward, especially in the areas that you're working?
I have a strong opinion, so I don't know. What about you guys? No. Well, yeah, I think, the Affordable Care, you're right on target. The Affordable Care Act, the folks that I know and love and care about, people who live at below 133% of poverty will have access to health care in a way that they never have before in the history of this country, and that's very important. And you're right about the accountable care organizations. The Affordable Care Act actually is pushing us to work much more collectively and cohesively around, in a very patient-centered way, so that people don't have to go randomly, willy-nilly to all these different programs who don't speak to each other and have different missions and things like this. So getting a little bit at May's point about, a centralized versus decentralized, this would be a much more centralized, coherent way of getting all of our healthcare. This will affect all of us, of course. And so I think from a harm reduction perspective, this is absolutely essential. Housing, we say things like housing is healthcare. Harm reduction is an absolute, it's absolutely essential for people to have good health outcomes, for us to talk openly and honestly about everything that's going on in their life, especially drug or alcohol use. And for people who are ready, willing, and able to engage in a pure abstinence-based program, this will give them the option to do so. And hopefully we will also more fully develop our whole continuum that is inclusive of abstinence-based and then all the steps that lead up to abstinence-based treatment too, like methadone maintenance and other opioid substitution programs and just even safer using programs. So,
do you think people who feel stigmatized by Stephanie, this was something that you had brought up, or whether it was accurate or not, they certainly felt the stigma associated with providers. you know, this population, as healthcare is made available to them, are they going to use it?
You know, I think that's a great question. And, you know, one of the things that comes up too is that from the provider perspective, there's this other element about dealing with complex needs clients or complex needs patients. And we know that some of the discriminatory aspects or the frustration that providers are experiencing is because they don't know how to work with clients effectively or patients. It's from the perspective of cultural competency to needing support infrastructure. They have a patient in front of them that they don't know what to do with because housing is the issue or substance abuse, all these other pieces. So one of the concerns I have is, I mean, yeah, we're working towards the PCMH model, you know, the primary care, you know, model of a medical home. And so this sounds good on paper, and I'm really hoping it works. I mean, I just have some concerns that I think it's going to take a while, many years for us to really become the type of providers in this wraparound system and, you know, all these elements that we're hoping to accomplish. And hopefully this step will be the first of a larger plan. Because what's going to happen is I think we're going to have more providers being more frustrated for a while and some difficulties in really connecting all those services together. And patients will see that, and they're not going to have that trust right away. It's going to take a long time. But luckily, when you start to make inroads, you know, word of mouth carries across the board, and when people see results, they do start to talk and those relationships get built. So.
Are there any more questions? Anybody? Anyone? No? Yes? Go ahead, Don.
I want to ask Maeve a question about China. You said it right away, it's illegal in China, but people are willing to self-report. Does that mean that they're not prosecuted? Why are they willing to do that, and why do they think the government will not come after them for breaking the law?
So your question is about the illegal status of drug use and also prostitution and all those things. In fact, this is not only a public health issue, it's also a public security issue. It's also an issue about human nature, right? And I think in China, you see, with drug use illegal, but under this kind of overall umbrella, then for NGOs or for the government, we do need to realize that we do need to do something. We can't just wait. So it's a kind of harm reduction we introduced. If we can't stop them from using the drugs, then the second option, the second best is find some alternatives. So that's why MMT is introduced. And for prostitution, in fact, that is highly correlated or highly associated with poverty or with those kind of, you need to look at both sides, supply side and demand side. If there is no demand, no supply, just like just like 40 years ago in China during the Cultural Revolution, when I grew up, I never heard about these things. But with the open door policy and also with the market economy or those things, these are new issues. Maybe it's not new, but a kind of, you see what I mean? Yeah, but also here in this country, we also share somewhat similar issues. But but maybe the government's effort or their strategy in tackling with those issues can be quite different, right? But for NGOs, sometimes NGOs, especially international NGOs, they do share a lot of similarity in tackling with these issues. I think harm reduction is a good or kind of second best solution to this issue. At least we can do something. Whatever the entry is, at least we can make some efforts.
Any more questions? I see some. Reverend Green, you have a question. Could you?
No, it seems you know everyone.
No, she doesn't.
Yeah.
I want to, wow, it really works. First of all, I want to thank the panelists because as I sat here and listened, I learned quite a bit. I took lots of notes. So thank you so much. It was very enlightening for me. And I'm sure other people felt the same way. But what I didn't hear, and I think I probably heard it, but I didn't hear it actually spoke about, is corrections when it comes to harm reduction. I've been fortunate enough for the last 30 years to work in the field of corrections, working with people coming out of prison, people in prison, the family of prisoners. And in the last 2 years, we've organized a harm reduction for prisons. It's called the Harm Reduction Prison Coalition. And within that coalition is formerly incarcerated people at the table in the planning stages of everything that we're doing, because they are the ones that can help us come up with some solutions around harm reduction, what it looks like. We're working right now on harm reduction in prison around condoms availability in prisons, because we feel that that's a harm reduction tool. Now, we can't say condoms to our legislators in Springfield because they get a little upset about that. So we just say harm reduction tools. See, it's all about language. And we can't say distribution, because that's like giving a prisoner a condom. So we have to say harm reduction tools accessibility, making them accessible, because it's many states that's already doing this, whether we know it or not. They're available in other states. But addressing your statement about interacting with the people that we're serving, it is so important, because what I've learned from research is that 2/3 of the people that are released from prisons are rearrested at some point. But there's that 1/3 that no one talks about. And that's the people that's out here on the front line trying to make a difference to help those that they left behind in prisons. And those are the people that I work with in Man and Women in Prison Ministry and through the AIDS Foundation of Chicago. There is a group of people in the community that want to help those that are incarcerated because they once were incarcerated too. And those are the ones that are valuable to all of the programs, all of the development, all of the strategies that we're doing, is the people in corrections that were once there and can give us a help. So thank you for allowing me to say that.
Thank you so much. And thank you. And I know we're really behind. I see the second panel sitting there waiting. So I just once again like to thank all of our panelists for taking the time out of their day, for flying, driving, taking the L, whatever it may be, to come and share their information. And I really hope I can give everyone access to their emails, and if they have PowerPoint presentations or things of that nature, we can I can either email it out to you if you'd like to contact me, and we can put it on our website, so that there might be some things that you'd like to look at in more detail. So look for those things soon, and thank you so much. I really appreciate it.